Okay, folks, I'm gonna get started at 8 o'clock. All right, so today we're gonna do dermatology and then probably switch to start hematology. Because derm isn't that big of a topic. You've already had dermatology, right?
Yeah,
You've had dermatology.
yeah.
Okay, so because you've had dermatology, I do not have to go over the various layers of the skin. You know that the skin is the largest organ in the body. Um, and I'm not going through the various layers. And dermatology has its own language. And if you don't understand the language, the definitions are there in the notes. I'm not going to sit here and read out all the definitions of what papules, macules, vesicles, etc. are. Okay, so we're just going to start with the skin of the neonate, and the skin of the neonate is very different than adult skin. It has less hair, it has fewer sweat and sebaceous gland secretions, and it's thinner and has weaker intercellular attachments so that any damage can spread easier below the skin. Okay. Um, it also drives mothers stark raving mad. Okay. And we're going to talk about the lesions of the newborn. I am convinced that every new mother leaves the hospital with a magnifying glass so that they can go over and look at all the lovely spots and bumps and lumps that a baby has. So the first one is milia. I'm sorry I don't have a picture of milia. All right. Um, Milia are superficial epidermal inclusion cysts. Okay. They're about firm papules 1 to 2 millimeters in diameter. And generally, they appear as pearly opalescent white. And generally, it's over the face, forehead, cheeks, nose, and gingiva. If it appears in the gingiva or in the midline, we call them Epstein's pearls. So those are milia. Sebaceous hyperplasia, again, are 1 to 2 millimeter papules. And what we're talking about are these things right here, okay? And instead of being pearly opalescent white, these tend to be yellow-white papules. And basically, they believe it may be due to a sebaceous gland response to maternal androgens. And okay, and this is a closer up. These are the things we're talking about right here. Okay, they're not very large, but every mother notices them. So that's milia and sebaceous hyperplasia. Now,
they're both benign.
What?
They're both benign.
They're both benign.
Don't do anything about it. Just leave them alone.
Yeah, we don't treat these. We just leave them alone. It's reassuring the mother, basically. Now, there's something called the sebaceous nevus of Jadson. Okay, which is this thing. Okay, and this is generally in the scalp. Okay, it's a hairless lesion of the scalp. It may be skin colored, or in this case, yellow orange. If it's skin colored, it looks this way. Again, hairless area in the scalp. Occasionally, it can appear on the trunk, but most likely it's in the scalp. The risk of malignancy is very small. It's less than 1%, and the risk is a basal cell carcinoma. And obviously, it's only when the kids get older and they've been exposed to a lot of sun without sunblock that increases basal cell carcinoma formation. So that it may be. I've never seen this requiring surgery ever, but there's always the risk of this requiring surgery. So that's sebaceous nevus Jadson, and then we have this one. Okay, and these look like bug bites. Okay, father comes in, my dog has fleas. or is being eaten alive, or they're being eaten alive by mosquitoes. Okay, this is very common. Okay, it's benign, it's self-limiting, it's asymptomatic. We haven't a clue what causes it. It occurs in about 50% of term infants. It's less common in premature babies. And these are yellowish to white papules, okay, on an erythematous space. Okay, a closer up with this, and here's the papules on an erythematous space. They look like bug bites or flea bites. And, we see these, they may be present at birth, they may show up as late as 10 days after delivery. Usually, we don't see it in the newborn, and then they come in 3 days later, and you see a few of them beginning to form, and they can spread throughout over the body. Okay, and if you aspirate these, okay, you put a small needle in there and aspirate them, and do a right stain, it's filled with eosinophils. Now, in the dark days of medicine, how do you know it's not a staph infection? Because it doesn't look like a staph infection. But for busy work for residents, aspirate it, do the stain. Okay, this is a clinical diagnosis. It's easy. When I see it, I tell the mother this is going to go away. It doesn't require any treatment whatsoever. It's not a problem. Okay, yeah.
How long does it last? How long does it last?
2 to 3 weeks. Drives the parents crazy. Okay, but it goes away. There's no issue with this. Then we have Milia crystallina. Now, these are 1 to 2 millimeter vesicles. Okay, so we talked about papules, now vesicles. Okay, and this results from obstruction of sweat glands with retention of sweat within the epidermis. So, parents will overcook their babies or dress them in, it's 100 degrees outside in 6 layers, okay, may have Milia crystallina, okay, and basically these are vesicles that rupture spontaneously, and if you look carefully after they rupture, you might see a white scale. And what's the white scale? Dried sweat. Okay, when the sweat dries up, okay, it leaves the salt over the wound, and that's what it is. That's Milia crystallina. Now, Milia rubra, okay, are now 2 to 4. They're larger. So these look, well, these don't show up very well, but this looks a lot larger than the 2 millimeter papules. These are 2 to 4 millimeter erythematous papules, or they may be papular vesicular, and this is what we call prickly heat. Okay, and basically there's deep obstruction to the sweat glands so that the sweat leaks into the dermis. Okay, Milia crystallina is epidermal. This is deeper into the dermis. That's why they're red. There's more inflammation. And once again, this is due to obstruction of the sweat glands leaking into the dermis. And this is what prickly heat looks like. So this is Milia rubra. And then we go to neonatal acne. Now, we used to call it neonatal acne. Okay. We used to call it infantile acne. Okay. But the dermatologist went and differentiated between neonatal acne and infantile acne. Okay. So this says infantile acne, but these are neonatal acne. Okay. 20% of infants, normal babies, may develop neonatal acne. It's more common in males than females. There may be open comedones, pustules, okay, like you see on the slide, okay? There are the pustules, open comedones, and pustules, okay? And we don't know what causes it. We know it generally starts at 3 weeks of age and generally basically can last until they're about 3 months of age. It goes away spontaneously. The theory has been that it's secondary to placental transfer of maternal androgens and maybe a hyperactive neonatal adrenal gland. But again, these are postulates. Nothing's been proven, okay? Or it may be an end organ hypersensitivity to the androgens. We don't know. Does not need treatment, goes away, no problems, okay? It may be as severe as this, okay? Or again, as this one. This is all neonatal acne. No treatment necessary. Why did the dermatologist suddenly start with infantile acne? Well, number one, it begins later. It begins after 3 months of age. It can last for as long as 16 months of age. Okay. It's more common in males than females. Again, the etiology is unknown, but this may resolve spontaneously in 4 to 5 years. So infantile acne may be longer and more protracted, and particularly if there's a family history of severe acne in one or both present parents. Okay. And if there's a severe history of acne in one or both parents, and these kids have significant acne, and again, open and closed comedones predominate. There may be pustules or nodules can be seen. So obviously, this is a more severe case of acne. These kids get treated. Okay, these require treatment if they're forming nodules, which may cause scarring. Now, this is infantile acne. Now, there's always a caveat in patients who have this acne that begins later, looks more severe. If there are increased growth parameters, okay, they're growing faster than normal, okay, or there's body odor, or you see pubic hair, breast development, testicular enlargement, you have to work these patients up for excess androgens because they may have adrenogenital syndrome. Okay, so if there's stuff there and the acne may look more severe, it may begin later. But if there are other stuff going on like body odor, development of secondary sex characteristics, pubic hair, you want to rule out androgen excess on these particular patients. So that's why they separated infantile acne from neonatal acne. I've never seen infantile acne. I've never seen babies who have acne severe enough after 3 months of age that they require treatment. So it's not very common. Neonatal acne is very common. You will see it on a regular basis. Infantile acne, you won't see. All right, so that's the neonatal lesions. Now, what about congenital pigmentary lesions? So the first one is Mongolian spots. Okay, these are these dark purple pigmentation. They're flat, they're slate gray to blue black. They're poorly circumscribed. We really don't see where these things end. Generally over the lumbosacral area and the buttocks. It occurs in about 90% of African Americans and Orientals and only 10% of Caucasians. We do nothing with these. They usually fade by 7 years of age. They have no significance whatsoever. So that's Mongolian spots. Then we got this one. This is melanocytic nevi. These are benign clusters of melanocytic cells. Okay, this is the most common tumor of childhood. There's a familial tendency. You tend to see them in families. Okay, and most people acquire these throughout childhood. They're not present at birth. Some may be small, hyperpigmented spots, but generally they peak in adolescence or late childhood. They have smooth borders, sharp demarcation from the surrounding skin. They may have hair, and there is a minor risk of conversion to melanoma. The more lesions you have, the greater the risk for transitioning to a malignant melanoma. And the more sun exposure you get, the more likelihood you're going to have more of these. So yeah.
Oh, when would this melanoma develop? Would this be in your infant it's getting melanoma or later on?
Oh, later on. Okay. And obviously, the more exposure to sun, the more of these you're going to get, the greater the risk. So that's the melanocytic nevi. Now, this is the disaster. Okay. This is a giant hairy nevus. giant pigmented nevus, okay? And this is a problem. Number one, it doesn't have any distinct borders. Number two, the pigmentation is irregular. All right. This is usually present at birth. It can occupy an extremely large area. It's very rare. It's 1 in 20,000 births. And obviously, there's uneven pigmentation, elevated hair, and 5 to 10% of these patients will undergo transition to malignant melanoma. And if they by the age of 5, so this is the one that's a disaster. And basically, the mortality is high as 45%. So what the heck do you do with these? Okay, you remove it all. Well, you can't remove it all. Okay, so what they've done to remove these is something very remarkable. They'll make an incision in normal skin here and up here. They'll insert a balloon, and gradually over time, they'll just continually to inflate the balloon. And as the balloon gets larger and larger, skin stretches. So the skin stretches and stretches and stretches. And then when they have a significant area here, they'll resect a portion of the tumor here and here, and then wait. And then again, as the skin heals, they'll put in another balloon, blow it up. So after multiple surgeries, this thing can be successfully removed. It takes a long time, but that you got 5 years before it turns into a malignant melanoma. They can resect these things with reasonable success.
Is it like genetic?
What?
Is it genetic at all? Like, what a
I
chance
have
to get
no idea. I've only seen one. What's this? What? This is what a malignant melanoma looks like. Okay, ABCs. Okay, the appearance, the borders, the color. Okay, this is what malignant melanoma looks like. Okay, fortunately, I don't see it in kids, but that's what these things look like. Okay, then we got this one. This is an epidermal nevus. Okay, we're talking this thing right down. Okay, this is maybe at birth or may show up somewhere after the first month of life. Affects both sexes basically equally. It's elevated, linear, widespread lesion. Cosmetically, these can be removed with no problem whatsoever. They don't undergo malignant transformation, except, and there's always the exception, okay? It may, and we're talking about rarely, not every one of these, may be associated with skeletal, vascular, and CNS lesions. So if you ever see one of these and say, okay, it's benign, we're going to resect it, we'll cut it out, no big deal. In the back of your head, is there, any other thing going on that I may be missing? Of all the ones that I've resected, none of them had any complications of skeletal, vascular, or CNS lesions. I show you this one. This is one you'll never see. This is hypermelanosis of Edo. And again, anything that looks weird, okay, and it's not smooth and even, okay, is a problem. This is associated with multiple neurologic diseases, and this one is a widespread epidermic verrucous lesion. And again, well, if you look here, here's an epidermal lesion, so I sit right in here. But these are multiple lesions, again, uneven borders. These have to be removed as well. Again, extremely rare. And then I showed you this one. This is cafe au lait spots, so we don't have to go over these. Okay, this one. Okay, this is the ash leaf patch with tuberous sclerosis. Okay, and the other complications are adenoma, sebation, which I showed you. All right. Then we go, okay, to the congenital vascular lesions. And there's this one. The first one I don't have a picture of. It's called the nevus flammus or stork bite lesions. Okay? The 30 to 40% of all babies have this. I think it's even higher. Okay? These are flat lesions, flat vascular lesions. It's over the nape of the neck. Okay? It may be between the eyes or over the eyelids. Okay? It may be below the nose. These are flat lesions, okay? They call them stalk bite lesions because if it's over the nape of the neck, it's where the stalk grabbed the baby to drop him down the chimney. So that's where the stalk bite comes from. These are flat erythematous lesions. They're not raised. They all fade. No matter where they are, they usually fade, but usually by the time the kid is somewhere between 5 and 7 years of age, I mean between 1 and 2 years of age, they generally fade. They require no treatment whatsoever. The next one is the capillary hemangioma, which is this thing. This is not present at birth unless you're really good. Okay? At birth, it may show up as a faint macula. Okay? And the faint macula will be smaller than this thing, about half the size of this thing. And it's hypopigmented, faint macula. Okay? And then it begins to grow, and they grow fairly rapidly, anywhere from a half to 4 centimeters in diameter. Occasionally, it may be larger. Okay, girls are more affected than boys. And if you do nothing to a solitary lesion like that, most of them involute by 60% of them involute by the time they're 5 years old. So you get something that looks like this, that goes to this, that fades to this. Over the labia, got something like this, that fades to that. Okay, 10% of the patients may be left with some small cosmetic defect. Most of them fade without any defect whatsoever. So what's the big deal? Okay. Well, part of the problem is we now have a treatment for this. Okay, and we have found, okay, that certain lesions are alarm bells. Okay, so if you have 5 or more lesions, most of them are single solitary lesions. I had one young girl who had one right there, right in the middle of a party. So every one of her baby pictures were taken with a hat down to her eyes, so it didn't show up in the baby pictures. Okay, it faded away with no significance, no cosmetic defect, nothing. So if you have 5 or more, you need a liver ultrasound. Why do you need a liver ultrasound? Because you have 5 or more of the skin, you may have them of the liver as well, and there's a potential issue with that. Okay, if there's a facial lesion greater than 5 centimeters in diameter, you need an echocardiogram because it's been shown that a facial lesion of greater than 5 centimeters in diameter, the patient may also have a transverse coarctation of the aorta. So if you have one on the face that's growing rapidly, you need an echocardiogram because we usually don't do blood pressures in very young babies to rule out coarctation of the aorta between the upper and lower extremities, and the femoral pulses may be equivocal. So if there's one 5 centimeters in diameter or greater, you need an echocardiogram. And obviously, if it's over the lumbosacral area, you need a sonogram to rule out a tethered cord, or a CAT scan to rule out a tethered cord. Okay, so these are the issues that are out there that you have to pay attention to. Now, cosmetically, can we get rid of these? I have mothers who have them on their finger and want to get rid of them. And yes, the treatment for this currently is propranolol. Who figured out propranolol makes these things shrink up? One cardiologist in France was treating kids with propranolol for their cardiac lesions and noticed that the hemangiomas cleared up by themselves, and basically that's how the diagnosis was made. Okay, there's just one problem with using propranolol in kids. What are the side effects of propranolol? What? The big one. What's the biggest side, besides hypotension, because that's what you use propranolol for, right? Elevated blood pressure. What is one of the major symptoms of propranolol? Side effects. Anybody know? Hypoglycemia. And babies don't eat on demand when you give them their medicine. So basically, the risk is if you're using propanolol to treat these babies, you have to make sure that they're eating so they don't wind up with significant hypoglycemia and have a seizure from hypoglycemia because you're treating a cosmetic lesion that really doesn't need it to be treated. Okay. Um, Other side effects that have been reported were just excessive sleepiness, cool extremities. Okay. Sleep disturbances. I mean, the increased GERD have all been associated with the use of propanol. So I'm not a fan of using it for small cosmetic lesions, which will go away all by themselves if you do nothing. Obviously, if a child has a significant lesion over the face, okay, or again, multiple lesions and hepatic lesions, you're going to want to use propanolol in these kids. And a recent report that just came out this year about using topical propanolol instead of giving it orally, topical propanolol with the lesion with an occlusive dressing for 2 to 3 hours, okay, has been shown to decrease the size of these lesions as well, okay, and it has the same side effects as if it's given orally. So that's another issue that you have to pay attention to. Then you have this one. This is different. Come on. This is a cavernous hemangioma. So again, this hemangioma is now raised with vessels deep below the skin. Okay, the strawberry hemangioma is a collection of um, capillaries, and basically they disappear by themselves because the the capillaries don't continue to supply the superficial lesion, so they shrink up. But these are vessels deep below the skin. They have a bluish discoloration. The borders tend to be indistinct. They may or may not be compressible. Okay, and these can go away on their own the same way as the superficial ones do. Okay, I had one young lady who had a strawberry hemangioma, a capillary right here on her head. Okay, so every picture of her was with a ponytail sideways covering up the lesion. She's now a college graduate actuary. It's gone, no stigmata. Okay, but what's the potential problem with this one if it gets larger?
Right?
It can compress the eye. And if it compresses the eye and goes down this way, you're going to lose the vision in that eye. So this is the kind of lesion that should be treated for propanolol. And this is definitely a lesion, this one, that should be treated with propanolol. This will shrink up completely with propanolol. In fact, this will shrink completely if you do nothing. But by the time you do nothing, the vision at this side may be an issue. So this kid would benefit from the use of propanolol. And then you have something that looks like this. Well, this kid obviously has more than 5. Okay, so you definitely want to do a sonogram of the liver on this kid. But if every one of these things are capillaries that are growing, okay, just think of the increased cardiac output you need to perfuse single one of these. This hemangiomatosis, these kids can go into heart failure because they have so many large lesions that require increased circulation. So that's an issue as well. Then you've seen this one, okay? This is your port wine hemangioma. This is not the Sturge-Weber syndrome. That's the kid who develops the seizures and what have you. This is purely cosmetic. It's over the distribution of the trigeminal nerve. Okay, these are present at birth. They never enlarge. They may be anywhere from basically red to dark purplish in color. They're macular. Okay, and again, you want to make sure that, again, it can also occur in the mucous membranes and hopefully not over the meninges. These can be treated now. Okay, for years we didn't have treatment for this stuff. Yellow pulse dye laser treatments will get rid of these things cosmetically, but it takes a long time because you can only do small sections of a time, and the child has to be sedated because it hurts, right? And again, with long-term cosmetically, you can get a pretty good resolution of this. Okay. The next one we just skip. Okay. And now we're going to talk about the big thing that every mother has to deal with, and that's diaper rashes. Okay. Now, we do not treat all diaper rashes the same way. We make a distinction of what's causing the diaper rash and treat it appropriately. You don't use a combination of steroids, antifungals, and anything else you can think of anytime a patient has a diaper rash because you don't know what the hell is causing it. You should be able to differentiate what the lesion is due to. And the most common cause of diaper rash is now known as diaper friction dermatitis. Okay, why diaper friction dermatitis? Okay, basically these are lesions over the convex surfaces of the diaper area, but the skin folds are spared. In the bad old days, we thought it was due to contact with urine and feces, and it occurred even if the mother changed the diaper every hour. Okay, you still got the diaper rash. So obviously, it wasn't due to contact between the urine and the feces. So grandma used to blame mama for being a lousy daughter-in-law for being a lousy mother when her kid got the diaper rash because she was ignoring the child and not changing the diapers. Okay, then somebody decided it was due to the ammonia and bacterial inflammation. Okay, in the urine and stool, and then they measured the ammonia levels. And it had no correlation, and there were no pathogenic bacteria causing these diaper rashes. So again, that's not the etiology. So the current medical opinion as the etiologies of these diaper rashes is Costco. And why is it Costco? Because a mother goes out and buys 10,000 newborn diapers, okay, the biggest package she can buy, and the kid outgrows the diaper size, especially if she's breastfeeding, in 2 weeks. Okay, the theory is the most common cause of the diaper rash is diapers that are too small. If I rubbed your skin nonstop 24 hours a day from diapers, your arms would get red and raw as well. And I can tell you that every time I see a baby who's beginning to develop a diaper rash, okay, and I say they need larger diapers, the answer is I still have some left. Okay, and my answer is save it for the next baby. These diapers are too small. You can't put them on, or the rash is going to get worse. And it's real easy to see. They're getting linear lines from where the diapers are constricting the legs. Okay, they're beginning to chafe. So the treatment is bigger diapers. Okay, you want to use an emollient cream or a base. Okay, yeah, that may help. But if the diapers are too small, it will not work. And this is the most common cause of diaper rashes. We see it all the time. And students in my office, when I said this, they heard it over and over again. I still have some left. Okay. The next one is perianal dermatitis. This is erythema around the anal area. It's most commonly the result of diarrhea stools. Oh, it's more common in bottle-fed than breastfed infants. And again, it once was thought to be due to alkaline stools, but then somebody did a study doing the pH of stools among babies, and it had nothing to do with the pH of the stool. Occasionally, it may be the result of candida, but the majority of cases with perianal erythema, we have no idea what causes it. Now, if there's perianal erythema and every time the kid has a bowel movement, they scream and there's blood in the stool, you want to rule out a strep infection. Okay? Either with, a culture or a rapid strep test, okay? And if it's present, then you treat them for the strep infection. There's one weird diagnosis, lichen sclerosus, endotrophicus, where the perianal area isn't quite red. It tends to be um, whitening or shiny appearance, and this has no significance and tends to disappear with adolescence. Okay, then we have candida dermatitis, and if you look at candida dermatitis, okay, it basically uh, involves basically involves this the skin folds, okay, the convex surfaces of the area, okay, and the hallmark of candida is they have satellite lesions at a distance from the erythema you see. This one's being treated. Normally, it's raw and red, okay, involving basically the perineum, inguinal folds, scrotum or labia, lower abdomen, and perianal area, okay, and generally it's very red and raw with pustular or vesicular pustular lesions. The hallmark, like I said, is satellite lesions next to the away from the original skin. This is cancer. Now, it usually shows up somewhere between 6 or 8 weeks of life, and it may be associated with oral thrush. And if it's associated with oral thrush, not only do you have to treat the diaper area, but you have to treat the thrush lesions in the mouth, because if you don't, every time the baby swallows the spores of the candida and has a bowel movement, they're going to reseed themselves with the infection. So basically, the treatment is nystatin or lotion cream, which are antifungals. Okay, leaving the diaper open to air will help because you won't know fungi like nice, damp, wet places to grow. And what's better, damp place than a nice, wet, warm diaper area. So basically, if you leave the diapers open to air, you'll get a more rapid resolution of the problem. It's easier with girls and boys to leave the diaper open because boys will spray the whole wall, every part of the crib when they void, but you leave it open, it will help. Um, and again, if the mother is breastfeeding and the baby has thrush or the baby has a candida diaper area, you have to inquire about the conditions of her breast. If her breasts are red and raw, weeping, tender, you may have to treat her with nystatin as well as the baby, because otherwise, every time the baby feeds, he's going to suck on a breast that has candida, ingest it, and continue to seed themselves. So you will have to treat both the parent and the baby. Now, if it's not only if it's really intense and raw, you may need a combination of nystatin and 1% hydrocortisone cream, the hydrocortisone cream, to reduce the inflammation as far as that goes. Okay. The one thing we do not use with babies is fluorinated steroids. Okay. Why did they fluorinate steroids? Why did they add fluoride to steroids? Anybody know? They didn't tell you in dermatology. Okay. Fluorides increase the absorption rate of the steroid. Okay. Increase the absorption rate of the steroids. Did they talk to you about classification of steroid strength from class 7 to class 1? Well, the fluorinated steroids are class 1 and 2. Okay. What else increases absorption of any drug besides fluorinated? If you want to increase an absorption of a drug through the skin, okay, what do?
Surface area?
What?
Maybe increase surface area?
That's possible, but what else? What are the skin absorbed birth control preparations? What do you call them? Or the nitroglycerins?
Patch?
They're a patch. An occlusive dressing increases absorption. So when we're talking about propanolol for the treatment of hemangiomas being topical, those were with an occlusive dressing for 3 hours to increase the absorption of the medication. So you don't use an occlusive, you use an occlusive dressing to increase absorption. What's a diaper? It's an occlusive dressing. And when the makers of Lotrimin, way back when, came out with a product called Lotrizone, which was a combination of Lotrimin and Dipersone. Does anybody know what level Dipersone cream is or ointment? It's a class 2. The cream's a 2, the ointment's a class 1. Okay? And they were promoting it for the treatment of Candida diaper dermatitis. And now it has a black box warning because the occlusive dressing increased the absorption of this fluorinated steroid and caused adrenal issues, okay, and thinning of the skin. So we do not use class 2 or 1 or 2 drugs in the diaper area. Okay, you do not use Lotrizone for the treatment of Candida diaper dermatitis because you'll suppress the adrenal secretion due to the heavy dose of absorbed steroids through this occlusive dressing. So that's why we do not use fluorinated steroids in children, period, let alone in the diaper area. Okay? The next diaper rash is seborrheic dermatitis. This one only involves the skin folds. It does not involve the convex areas of the diaper area. Okay? And basically, this is the same as seborrhea of the scalp. What do we call seborrhea of the scalp? Cradle cap. Okay? Those scaly lesions of the scalp that babies get is cradle cap. It's seborrhea. Seborrhea in the diaper area, okay, has a scaly yellowish color, and when you feel it, it may have this greasy or soapy quality, okay? And these, okay, may not only be in the diaper area, you may see it in the scalp, you may see it in the axilla or the neck, okay? And the treatment for seborrhea is just steroids, okay? 1% hydrocortisone or 2.5% hydrocortisone is enough to clear up seborrhea, both in the inguinal area in the diaper and for cradle cap as well. So that's basically seborrheic dermatitis in the diaper area. Bullous or pustular dermatitis. I showed you this when we did neonatology. These are superficial pustules or large fluid-filled vesicles which rupture and leave raw areas. The etiology of this staph may be strep, and the treatment is antibacterial washes, topical antibiotics, or in severe infections, oral antibiotics. Less common lesions in the diaper area, one is psoriasis, okay? And generally, psoriasis may first appear in the diaper area before it appears anyplace else. They frequently become infected with Candida. When they heal, it can lead a granulomatous angioma. We don't know what causes it, okay? But if you use steroid cream on this stuff, it may prolong their presence. If you ignore it, the psoriasis will fade in 2 to 3 months. Pseudomilia crystallina, small vesicles on an erythematous base. This is basically prickly heat in the diaper area. Okay, we often see these in babies whose mothers don't want to use disposable diapers, so they use cloth diapers. Then they put on a plastic covering on top of the cloth diapers, which really cook the skin below it. Okay, and you see these vesicular or pustular vesicular lesions, and you also, if you see it, you may want to rule out a staph infection. And basically, the treatment is keeping the patient cooler. Okay. Kawasaki's disease. You know what Kawasaki's disease is? Mucocutaneous lymph node syndrome. That's what Kawasaki's is. These kids are sick. They're not just coming to you with a diaper rash, okay? They're febrile, okay? They're irritable, They have mucocutaneous lesions in the diaper area, in the mouth. Okay, the rash is either edematous, bullous, desquamating. Okay, they're not there for the diaper rash. It's just a side effect of Kawasaki disease. And the last one that you may see in the diaper area is ectodermatitis enteropathica. This is a zinc deficiency. And basically, you're only going to see this in ex-preemies who are exclusively breastfed. And when the rash shows up, it's generally vesicular, bullous, or scaly. It may have a psoriatic appearance, but these kids are also sick. They're feeding poorly. There may be similar lesions around the mouth, the knees, and the elbows. Okay, and this improves with zinc supplementation. And again, this is not common. Basically, it's ex-families who are exclusively breastfeeding. So those are the diaper rashes. Then we get to this friend of ours. This is atopic dermatitis or eczema. This is the most common skin disorder of children. It affects 10 to 20% of all kids today. That's up from 5% in 1946. Why the increasing number of patients who have atopic dermatitis? The answer is the hygiene hypothesis. Just we're too clean, and because we're too clean, our body is setting up responses, okay, inappropriately to certain triggers, okay. This is frequently associated with increased IgE levels, okay. And basically, the rise in atopic dermatitis is also paralleling the increase in asthma that we're seeing today for the very same reason, okay, the inappropriate production of IgE antibodies against normal exposures. 80% of patients who start with atopic dermatitis go on to develop either allergic rhinitis or asthma. And again, when you have a patient who has atopic dermatitis and it's starting to improve and they start to ease, and then you start to treat their asthma, their atopic dermatitis gets worse because there's a balance between the two. Basically, it seems to be the imbalance of an end organ response. Is it the skin that's responding or the lungs that are responding? It's the same allergens that are triggering it. So, what are the predisposing factors? Okay, genetics. It's transmitted, familial transmission, generally from the mother's side more than the father's side. So if the mother had asthma or atopic dermatitis, there's a greater risk that kids will have it. There's a genetic predisposition, like I said, to secrete IgE antibodies inappropriately against environmental antigens. These patients tend to have dry skin with a lower threshold response to irritants, meaning pruritic stimuli. What are the irritants? Soaps, detergents. You know, we use a lot of soap, okay? And what does soap do? It removes the normal lipoproteins from the skin. So if you start with normally dry skin and you bathe a kid 2 to 3 times a day, which some people bathe their babies, their skin is going to dry out because you're removing the superficial lipoproteins of the skin. Also, exposure to chemicals, smoke, abrasive clothing, or extremes of temperature can also trigger this skin irritating pattern, making the skin more pruritic, leading the kids to scratch more. Food allergens have also been known to increase rashes in children with atopic dermatitis. 40% of young children with moderate to severe atopic dermatitis have been shown to have allergies basically to eggs, milk, soy, and peanuts. Those are the 4 big ones: eggs, milk, soy, and peanut. So if you have a baby who's developing atopic dermatitis to formula, you're not putting them on soy because that's the same trigger as cow's milk protein. So you have to pick something else to feed the baby if they're developing atopic dermatitis. Aero allergens triggering it are more common in the older kids, and the common triggers are fungi, animal dander, like dogs or cats. Okay, cats are worse than dogs, and we went over this when I was talking about asthma. Not having one cat, having 7 or 8 cats. Okay, so cats can do it. Grass, ragweed, dust mite. The presence of a dog in the household may have some protective value, and we don't know why. So there's a family history of atopic dermatitis. They want a pet, get a dog rather than a cat. Antibiotics, cephalosporins or macrolides early in infancy. Generally used 2 or more times in infancy, doubles the risk of these kids developing atopic dermatitis, and I can't tell you no idea why, but that's what it's been shown. Now, the pathophysiology of atopic dermatitis is explained by 2 theories, okay? And these 2 theories are leading to changes in how we treat them. The first one is the outside-in theory, and it's relative to filaggrin. Filaggrin is an epidermal protein that binds keratin fibers. It contributes to barrier functions, and it releases free amino acids that retains water in the skin, which means it keeps the skin well hydrated as opposed to let these dry that going on to dry, itchy skin. And in 2006, they found mutations in filaggrin um, that are involved in the early onset of atopic dermatitis. So this is possibly one of the genetic factors that results in these kids developing atopic dermatitis early. Okay. And basically, okay, the more severe the atopic dermatitis wind up to resulting in the increasing the inflammatory cascade causing the symptoms. So if the problem is this genetic defect, okay, which keeps water into the skin early on in infancy, then the theory is if you treat these babies with a strong family history of asthma and atopic dermatitis with emollients early in the newborn period, okay, then it may protect the baby from developing the skin lesions early on in infancy. The second one is the inside-out theory. This is secondary to PDE4 inhibitors. PDE4 is phosphodiesterase 4, and PDE4 is increased in atopic dermatitis. And if you have an increase in PDE4, you have an increase in cyclic AMP. Cyclic AMP increases the production of inflammatory cytokines, IL-4, I3, and 31, and the inflammatory cytokines increase the itching, the inflammation, and the breakdown in the skin. Okay, so the basic treatment is a PDE4 inhibitor. And a PDE4 inhibitor out there now is crisaborole. This is a boron-based PDE4 inhibitor. And this is why idiots on TikTok are taking borax because they think borax is the same as boron, and boron is obviously in certain concentration in certain foods. Okay, it's a 2% ointment. It's safe to use around the eyes. And if you ever write a prescription for crisaborole, this PDE4 inhibitor, you should be aware that it burns. Okay? I had a patient, oh my God. I have a group of people called the Three Musketeers Plus One. They're all teachers at one school. Okay? And they're all problems. The first one in the group, when she came to my office, would tell me, my stepfather, the internist says. And I would say, I'm not practicing with stepfather. Either you bring your kid to him or me, otherwise I don't want to hear what she says. She has no sense of HIPAA violations every year in the school when she goes through the medicals on the kids in the class. Oh, you go to Dr. Emmett. I take my kid to Dr. Emmett. This is teacher number one. Teacher number two, okay, had IVF because she couldn't find a mate. She's living with her mother and she's aging out of childbearing, so she has a kid. Okay, um, and one day her kid was 3 years old, had 105 fever, and I came to the office, and she shows up with her mother. Okay, and her mother's this is on a Sunday, and her mother says, "Where are your secretaries?" I said, "It's Sunday. I just came in to see a sick grandchild." Okay. Oh, I'll work for you on Sundays, and then we can hang out afterwards. This was grandma. This was number two. The child was still in bed with her mother, his mother at 7, because they were best buddies. Okay, that was child number three. This was a mother who came in who said to me, "I know what you do to newborn." Another IVF teacher. "I know what you do to newborns, okay, and you can't do it to my kid. Hold them out of your life because I have a brain tumor and I can't tolerate." And I said to myself, "You had a brain tumor, okay, and you're having IVF for a baby?" If the brain tumor turned out to be benign, the kid's a teenager now. She's like, fine. So these are the three musketeers, and then there's the plus one. Both parents are teachers. The father stands and cries every time I give his kid a shot, and he's a gym teacher. And this is the mother, okay? And this kid had a mild atopic dermatitis of the other eyelid. It wasn't bad. So I gave her an ophthalmologic preparation, Decadron ophthalmic, because if you put it on the eyelid and it gets in the eyes, no big deal. The mother wasn't happy with that. No, this particular mother has no concept of time. Every visit, she would write down word for word what I told her to do for her child. And then when she had a second child, she didn't take the old book and read it. Everything I told her, she was writing down. Okay, this was the plus one. She goes to the dermatologist and she sees the PA, and the genius PA gives them crisaborole to put on the eyelid because it's safe to use around the eyes. Except it burns like hell. If you have a 3-year-old and you're putting a cream on the eyelid that burns, what's going to happen? The kid's going to scream bloody murder. So the mother calls me up and complains to me. Why don't you complain? Complains to me that this cream is burning a kid's eye. I said, well, it's expected. I don't know why you're using it there. So the mother says, can I return it? I said, you can't return an open ointment. Maybe I can sell it on eBay. I had a $50 deductible that I want to get back. These are the patients you're going to see in the real world, folks. This is what's out there. Okay? So if you're going to use crisaborole, you don't want to use it around the eyes in young kids, even though it's safe to use around the eyes. Okay? And you want to tell the parent it's going to burn. Long-term use, the burning gradually decreases. But the first time you use it, it's going to burn like crazy. So this is the theories and the treatment. Okay? So what are the clinical manifestations of atopic dermatitis? Number one, it depends on the age of the kid. Okay? Most kids develop atopic dermatitis in infancy. 60% of them will develop atopic dermatitis before the first year of life, and another 30% are diagnosed somewhere between the ages of 1 and 5. So when you see atopic dermatitis, it's in young kids. Okay? 10 to 30% may persist onto adulthood, but many of them will develop to allergic rhinitis or asthma as they get older. And the biggest symptom of atopic dermatitis is itching, pruritus. Okay? Now, the infantile stage begins somewhere at 2 to 6 months of age. It begins on the cheeks, okay? The forehead, maybe the scalp, can go on to the extremities, and they're red, raw, and weeping, okay? And there's this headlight sign, which is right here, okay? See the two headlights? For some reason, These two areas are spared. I don't know why, but it can be red and raw all the way around here, up on the forehead. These two signs, these two areas are spared from lesions. These kids itch at night. They're up all night scratching. Okay. 50% will improve by 2 to 3 years of age and develop allergic rhinitis, and 75% of these will improve by adolescents with asthma or allergic rhinitis. This is the interparent phase. Then we go on to the childhood phase, and now we're talking about 4 to 10-year-olds. These are the ones who haven't gotten better, but the weeping lesions have changed, and now they have thickened skin, lichenification, okay? They're dry, they're papular, and now they involve the wrists, the ankles, popliteal and antecubital fossa, okay? And then dermatology talk about palmar linearity, okay? Increasing pigmentation of the palmar creases. And this is when they appear here, okay? And generally with treatment, okay, after treatment of these lesions, you may have hypopigmented areas secondary to the steroid use, frequently called footprints in the snow. But basically, these are the hypopigmented areas that occur with steroid treatment. And if you develop what's called nummular eczema, what does nummular mean? Coin shape. So these, you get these coin-shaped lesions, okay? These may require high strength steroids to get rid of. They tend to be more resistant to therapy. And the childhood lesions may clear by puberty or when it merges into the adult form. The adult phase begins around the age of 12, and now it involves, again, face, neck, flexor folds of the upper arms, back and dorsum of the hands and feet. And again, these are more difficult to treat. So how do we go about treating atopic dermatitis? Well, the goals of treatment, okay, one, you want to maintain and restore skin barrier function, okay? Emollients, bathing them and then putting the emollients on while they are still wet. That's when you're supposed to put your creams on, because the purpose of these emollients is to drive moisture back into the skin. If you put them on when you're dry, you might as well put them on the wall. They're not doing any benefit to you at all. Anything that you use will work. You can even use Crisco, okay? Nobody wants to use it, but the white, not the butter flavored, but the white Crisco in the blue can works just as well as all these fancy other emollients. Pump lotions do not work. They're too thin. You need the thick ones. You need Vaseline. You need Aquaphor. Okay? None of the pump lesions are any good. They're not thick enough. Okay? And basically, in the winter months, okay, the dry skin basically contributes to more problems in the winter months because the skin is drier, there's no humidity in the air, so they itch more. So if you're going to use soap, okay, you should use soap with a neutral pH. One of my favorite things I use, if I see a baby who's developing atopic dermatitis, my first thing is no soap and water. We know soap and water removes the lipoproteins. I use Cetaphil cleansing lotion, okay? And you just tell them to put it on a washcloth and wipe them down from head to toe. You know, it'll clean them, it'll take off dirt and what have you, and it won't remove the lipoproteins. And if I do this with kids who have dry skin, their skin improves almost immediately because a lot of these kids, grandma thinks babies have to be bathe twice a day because they're rolling around in the mud or what have you, and they're getting dirty. So stop bathing once or twice a week is enough. They don't have to be bathed every single day. You can wipe them down with Cetaphil, and they really do fine. Okay. The other thing is you want to improve the itching, um, and improve their sleep because we said the itching is worse at night and they're up all night scratching. So you use antihistamines, okay? And basically, the biggest antihistamine I like to use is hydroxyzine, okay? Or Benadryl, which you can use over the counter, not the current third generation antihistamines. Why? Because the third generation antihistamines are non sedating. And you want something that sedates the baby and makes them sleep. I tend to use hydroxyzine. Okay, it's a sedative. They sleep through the night. They stop scratching. It's 2 milligrams per kilo of body weight per day. It comes in a liquid. Okay, and if the mother gives them bedtime, we stop the scratching. You want to start eliminating, milk, soy, peanuts if you're giving it to them, because this may be triggering the allergic reaction. And topical glucocorticoids, okay, is the cornerstone of treatment. And on the face, we start with a class 5, destinide, okay. Um, Perioral lesions in babies, you do not use steroids around the mouth. Why? Because the baby's going to eat them, okay. On the trunk or extremities, triamcinolone, okay. For flares, more potents like mometasone or fluocinolone, okay. You never use ultra high potency steroids on the face or in the diaper area. Creams are less occlusive and have a lower rate of absorption. So you start with the cream. If it doesn't work, you go up to the ointment, okay. And then you can try alternation of PD in severe cases, alternating PDE4 inhibitors with tacrolimus, okay, for everyday use. Now, most parents don't want to use everyday use. They just want the magic steroid till it goes away. And then when it comes back, they want to start all over again. If you use the tacrolimus and PDE4 inhibitors, okay, um, this may reduce the severity of the disease. Okay, in uh, babies who come from families where there's a high incidence of atopic dermatitis, daily full body emollients, even before they develop symptoms, may reduce the atopic dermatitis risk. In infants, okay, they said if you start by 9 weeks of age in a newborn, it will eliminate their risk. A recent study will eliminate the risk of developing atopic dermatitis by 2 years of age. So this is a pretty good thing if you have a family high risk of atopic dermatitis. For preventing infections, bleach baths work. And bleach baths work for any skin infections. You have a patient who's developing repeated episodes of impetigo, repeated episodes um, of skin infections, MRSA, bleach baths. A quarter of a cup of bleach, okay, quarter to a half a cup of bleach in a bathtub. You sit them in the bathtub up to their neck, okay, for 10 to 15 minutes. They will no longer get skin infections, okay? And when everybody yells at you, oh my God, putting bleach in the bathtub, what's it going to do to their skin? What's in your swimming pool? Sodium hypochlorite, folks, it's bleach. Okay, basically that's what it is. Okay, so that bleach baths will not damage the skin. If people are all upset about bleach, just tell them it's the same stuff that's in the swimming pool, basically, and it's just a slightly higher concentration than what's in this pool because the sun breaks down the chlorine in the swimming pool. It doesn't last very long. I mean, chlorine in the swimming pool with the sun out, like having, should be checked every 2 hours and more added. And I know nobody does it. Okay. But I mean, that's so bleach baths are great. Now, if you have an older kid, okay, who's not going to sit in the bathtub, okay, but has skin lesions or severe acne, I mean, even for acne, okay, um, bleach will reduce the risk of skin infections. You can use something like Clinate. Basically, Clinate is sodium hypochlorite, and they can use it in the shower. And if they use it in the shower, you put it on, you leave it for 10 to 15 minutes and wash it off. Okay, it's the same thing as a bleach bath for older kids. Topical immunoregulators like tacrolimus for long-term therapy. Okay, the tacrolimus have to be used every day, and the advantage is one, they're not steroids, and two, they don't cause skin atrophy like long-term steroids can do. And then we have crisaborole that we talked about, the PDE4 inhibitor, and one of the newest things out there for severe acne, okay, is dipilumab, okay, which is an anti-leukin 4 receptor antibody. This blocks signaling by these IL-4 and IL-3. Okay, it's given sub-Q every other week, and these stuff clears up bad atopic dermatitis remarkably. If I have a kid with bad atopic dermatitis who's not responding to skin treatment, they're scratching, they're developing skin infections, we send them to the dermatologist, and their skin clears up in a matter of months. They do remarkably well. Probiotics. Does probiotics help for atopic dermatitis? If the mother has a family history of atopic dermatitis, and she takes it before delivery, will it help? Okay, we don't know. They did a study in children of Lactobacillus GG, and they gave it to children with atopic dermatitis. As far as I know, there were two studies. One study said it worked, one study said it didn't work. So I don't know about probiotics in babies. Okay, and what are the complications of atopic dermatitis? Well, this is one of them. This is where they scratch, they pick, they get secondary infection, and now they have scarring. Okay, you have atopic dermatitis and impetigo, so you have the scratch lesions developing impetigo. Okay, and if you have atopic dermatitis with herpes infection, this is what can happen. So this is all the problems with atopic dermatitis. Recurrent skin infections with herpes, okay, fungal infections or bacterial infections. 50% of patients with severe atopic dermatitis are infected with Staph aureus. Okay, now these kids have comorbidities. If you're up all night scratching, you're not sleeping well, you're itching all day long, you have increased risk of attention deficit hyperactivity disorder, excuse me, depression or anxiety, oppositional defiant disorders, obesity, hypertension. Okay, the greater the atopic dermatitis, the greater the risk of behavioral disorders. Then we have infectious dermatitis. Okay, and the first one is this kid. Okay, this is impetigo. Okay, there's two types: the non-bullous and the bullous. The bullous I showed you; these were in the newborns. This is not non-bullous. These are these honeycomb lesions. Okay, it's always caused by Staph aureus. It's manifested by, in severe cases, with scalded skin syndrome, and I showed you pictures of that with neurology. Okay, and this is the non-bullous. Excuse me, non-bullous. Okay, this is the majority of infections. Okay, 70% of all cases. Okay, it begins at face and extremities, and wherever they scratch and wherever they pick, they spread it to. Okay, it's separate washcloths, separate towels. It's highly contagious. Staph aureus is the most common etiology. Group H. Staph is the other one. Okay, and If it's localized, you can use Minocin. If it's widespread, oral antibiotics. The bullets is what we see in the young infants, okay, and I showed you what those look like, okay. Um, Severe, it's a kid with chickenpox, okay, and wherever he had the chickenpox lesions and he scratched, he developed non-bullous impetigo. This is what the bullous impetigo looks like. These the large vesicles that rupture. This is in the newborn. Okay. Golden skin syndrome I showed you when we did neurology. Okay. Scalded skin syndrome is also called Ritter's disease. This occurs in infants and children under 5. And basically, this is toxic shock syndrome in young kids. Okay. Because these kids, okay, do not have the antitoxin antibodies to staph. And the most common cause of scalded skin syndrome in kids is Staph aureus, particular for age groups. Okay, these kids are sick, they're febrile, they have exquisite skin tenderness, and then they develop a scarletiniform rash around the mouth and flexural surfaces. They develop conjunctiva with purulent discharge, and if you scratch the skin, they develop these bullous raw skin lesions. Okay, they're sterile. They require oral antibiotics. Okay, for 10 to 14 days. They get better without scarring. Toxic shock syndrome, you know about. Okay, this is a multi-system disease. High fever, vomiting, diarrhea, muscle aches, focal neurologic signs, conjunctival hyperemia, strawberry tongue, erythematous rash, desquamation of the hands and feet. Again, it's Staph aureus, but again, these are in people that have the antitoxin to antibodies. And these are generally late teenagers, early adults, okay? Females who are menstruating while using tampons or other vaginal devices. And you know all the complications of toxic shock syndrome. I'm not going over it because it doesn't happen in the pediatric age group. Scarlet fever we talked about, and then we got these guys. These are warts. Human papillomavirus, 70 different types of viruses cause warts, okay? The incidence is highest in children and adolescents. The incubation period is forever, 1 to 6 months, depending which virus. It can be transmitted by direct contact or auto-inoculation from scratching, okay? 5 to 10% of all children will develop warts. The common warts are HPV, human papillomavirus 2 and 4. Generally, we see it around the finger, the dorsum of the hands, the paronychial area, okay, face, knees, and elbows. Plantar warts are human papillomavirus type 1. Usually, it's flushed on the surface of the feet, and because of pressure, presents with pain. It may occur on the palms. All right, how do we treat warts? Okay, almost anything is effective. 50% if you do nothing will disappear over 2 years. Okay, non-treatment increases the risk because the kids pick and auto-inoculate. So options: wing of bat, eye of newt, dirt from a fresh grave. Okay, all have been used in the treatment of warts. Liquid nitrogen, cantharidin. You know what cantharidin is, right? Beetle juice from the blister beetle. That's cantharidin. Curettage, light desecration, lactic acid, salicylic acid, all have been used for the treatment of warts. Okay, single warts. You can use topical antifungals. But if you're going to use a topical antifungal like salicylic acid, okay, one of the things you have to tell the parents to do is take an emery board and file down the top of the wart. If you're going to use liquid nitrogen, file down the top of the wart. and then don't use that emery board for anything else. Because when you file down the top of the wart, you expose the virus that's sitting below that thick wart. Okay, you're not getting at it very well if you're trying to treat it through the thick wart. So what I tell parents to do is number one, file down the top of the wart, put the salicylic acid on, and then cover it with an occlusive dressing. Why? You want to force the salicylic acid down into the wart to treat it. Duct tape also works. Duct tape? Yeah, one of the cheapest things to treat it for is duct tape. File down the top of the wart, put the duct tape on top of it, wear it, and change it. Why does duct tape work? Because the glue of the duct tape sets off an inflammatory response, which mobilizes antifungal treatment. It does work. Okay? Now, what if you have a kid who has multiple warts all over their body? Are you going to sit there and curettage them all? Are you going to sit there and use cantharidin? Okay? Incidentally, cantharidin burns like hell if you're not careful and don't use it on normal skin. Okay? So basically, what are you going to do? Okay? There's been one report, okay, with the use of an H2 blocker, Tagamet. Okay? How did I know? I read the article. Somebody was using Tagamet to treat GERD on a patient and noticed the patient's voice disappeared. And I've used it on a couple of patients and it's worked. So if you have multiple warts all over the body, you might want to try Tagamet to get rid of some of the warts on these patients. Okay, so those are viral warts. Then what's this? You have dermatology. What's this? This is molluscum. Okay, basically the hallmark of molluscum is the belly buttons in the lesion. They start like this, but they all develop umbilicate. This is a pox virus. It's acquired by direct contact with infected persons. It runs through families. It runs through schools. The incubation period is about 2 weeks. And these are single or multiple dome-shaped lesions with umbilification. They can appear on the eyelids. Okay, wouldn't treat these. All right, and they may be as thick as these. Okay, and again, commonly they may occur anywhere on the body, and they are self-limiting. If you do nothing, okay, they can disappear in 6 to 9 months. Okay, they can persist for years. No washcloths, no towels, no bathing 2 kids together in the same bathtub, which is one of the ways. Okay, liquid nitrogen can do it. Okay, but basically, if you're sitting with a kid like this and you want to use liquid nitrogen on every one of these, they're going to be screaming bloody murder while you do it. Curettage, very much the same thing. So again, you want to be careful. Okay, there's now cantharidin, okay, out there, and it comes in a pen-shaped kind of dispenser, and you can apply it to each specific lesion. But if you treat too many lesions at once, or you get it on their skin, it's going to cause major inflammation of the skin. And so if you have a kid who has this many lesions and is not holding still while you do it, okay, all the area around the skin, these lesions are going to get inflamed. They're going to blister because it's a blister beetle. Okay, so putting it right directly on these lesions are a potential problem. I would stay away from doing it. They say it's easy to do. Trust me, it's not easy to do. Okay, then we start with this one. This is Tinea corporis. Okay, ringworm, infection of the non-hair-bearing areas of the body. Okay, Tinea rubrum and Tinea integrophytes are the most common. And the hallmark is a raised border with central clearing. That's typical of basically ringworm. The border tends to be scaly, and topical antifungals work for 2 weeks. Okay, Now, you should be aware that there is a new version of ringworm out there, okay? And it's sexually transmitted. And not only is it sexually transmitted, okay, it's basically trichophyton indotenaceae, okay? Basically, it requires prolonged therapy and it's resistant to most antifungals, okay? And it's transmitted by physical contact, sexual activity. So if you see ringworm, generally you want to ask about gym use, public showers, because this is where you can pick this one up particularly, and the CDC has reported this one, okay? Then we come to this one. This is Tinea capitis, okay? This is ringworm of the head. And if you have Tinea capitis here, you'd be very tempted to treat it with topical antifungals. You cannot treat Tinea capitis with typical antifungals because the fungus lies deep in the hair shaft and it's not getting there. Okay, so Tinea capitis cannot be treated by topical medications. Okay, it's commonly seen in Black and Hispanic children, 4 to 14 years of age. Trichophyton tonsurans or Microsporum canis and tumor common bugs. Okay, and here are the multiple presentation of Tinea capitis. Okay, at the neck area. This is Tinea capitis. Areas of alopecia. This is Tinea capitis. Black dot where you have fracturing of the hair shaft. This is Tinea capitis. This is a carry-on. This is not a bacterial infection. It does not require antibiotics. This is Tinea capitis. This is Tinea capitis as well, with heaped up scale cavity. All of them, okay, require oral antifungals somewhere between 6 to 8 weeks. So you keep this kid out of school for 6 to 8 weeks. So how do you send them back to school with a head that looks like this? Okay, ketoconazole shampoo, because how do funguses transmit? By spores. That's how funguses transmit infection. Okay? If you wash the hair once a week or twice a week with ketoconazole shampoo, it kills all the spores on the head. So these kids are not contagious and you can send them back to school. Okay? But it requires long-term treatment. Now, in the bad old days, the only antifungal we had is griseofulvin. And griseofulvin was always only absorbed with a fatty meal. But when I treated these kids with oral griseofulvin, I told the mother they could give it to them every night with ice cream. And then the kid didn't mind taking the medicine. Now they have other oral antifungals, some of which are hepatotoxic, so you should be aware of that. Okay, particularly when we talk about Tinea versicolor. Okay, Tinea versicolor is a common innocuous fungal infection. Okay, predisposing factors: warm, humid environments, aggressive sweating, occlusion, maybe high plasma level, cortisol levels, and genetics. We've seen this in the adolescent gym rats. The adolescent kids who wear the tight shirts to work out in, they sweat a lot and they get these lesions. And if you use a woods lamp, and you know what a woods lamp is, I assume, Tinea versicolor fluorescent gold under wood lamps. This stuff is difficult to treat, Tinea versicolor, okay? Topical fungals have to be used for long periods of time, and then they come back, okay? I used to use ketoconazole in the past, and I used to give them one huge loading dose of ketoconazole. And then I would tell them, take the dose, go to the gym, sweat like a pig, and don't shower for 12 hours. Why? Because they absorbed the medication, okay, got into their vascular system, and when they sweated, the ketoconazole was distributed through the sweat glands and killed all the Tinea versicolor that was below the skin. And now Tina Versicola ketoconazole has a black box warning on it for hepatotoxicity. So I have tried other oral antifungals for this, itraconazole, okay? And before I treat them, I have them do liver chemistries, and then I give them a loading dose, and I then do the same thing, because which is easier to do? Smear yourself with an antifungal for 12 weeks, or give yourself one loading dose of an oral antifungal, sweat like a pig, leave it on for 12 hours, wash it off. So that's how I treat these things. And I seem to have pretty good results. Okay. And the last thing I'll talk about, and then I'll give you the break, is tinea pedis, athlete's foot. Rule number one is children do not get athlete's feet. So you have a kid who comes in who's a non-adolescent with peeling toes and itchy peeling toes. Okay. Basically, what you want to do is ask him, okay, do you wear the same shoes or sneakers every day to school? And when you come home, are your socks soaking wet? Because this is maceration of the feet from wearing the same damn shoes to school and wearing the same wet socks. Okay? And if they have this, you tell them to get 2 pairs of shoes and alternate them. And when they come home, put on clean, dry socks. And if you treat them with borough solution basically is aluminum hydroxide. It's a drying agent. And if they soak their feet every night in borough solution, this will go away. You treat them with topical steroids. You do not treat them with antifungals. So treating a patient with antifungals is not indicated in children who have peeling toes. Okay? So take 10 minutes and then we'll come back, finish dermatology, and we'll start hematology.
You topical steroids. No one told us.
Borough,
Yeah.
what?
She has treatment.
Oh,
Just double checking.
Okay.
Thank you.
But we tired. I'm like, that like.
Yeah, my first time there was like actually 10 people there. I was like,
Are y'all agreeing with this last one? Like, what's happening? Yeah, why?
I'm gonna go watch this. Music? Yeah, I know it's awesome.
Yeah, we're okay. I don't think I did that. I don't think we're gonna get that. They're not bad. We're getting there. They're short. No, but they're all right. Like today, it's dermatology with dermatology together. We only have 2 weeks left. Oh, yeah, this is fine. Where, our, unless you bring it today, the next week. Maybe. They're short.
Maybe you can do that you are, and I, so. We're
So, my mom. Last year's question. So I don't really know. I would be like,
Yeah, it wasn't 8%, it was like, so the 20%. Yeah, it was evenly split, like I literally. The next question was just, yeah, what are the next stops there, it was in order. It was like in order. So, it was good though, I loved it. And then yeah. I really think each line is a whole thing. So they're like, so like, I just literally so but yeah, but it's on the best with me. Like find a super like yeah, a lot of people I mean by the way, I like this color. I was studying. Did he have another? Yeah, I like sometimes he's you're saying like people would rather, I mean, I'm getting more stuff. Yeah, so they should there. He does. She said you'll have Thursday, Friday, Saturday. But sadly, like they can't. Some elders, I'm like, pretty bad. So I just like itch it, and then like, yeah. Like I'll make it work. See what those little shops are. That's what I said. That's not like 2 days. I'm gonna make it. I know. Like, yes, they're all. Right. When are we getting calls? That's what I want now. Yeah. I like probably that.
Yes.
For the low specific gravity, it says less than 1.01.
That's it.
Normal is 1.00.
Yeah.
But it's higher than the normal.
I woke up at like 7.
It's less than 1001.
I believe.
In other words, it's a halfway.
Okay.
And a step.
Okay, got it. So we're now waiting till they get even to 1.001 to be on the low.
It's gonna be lower than that.
Yeah.
Okay, but that's
Okay.
lower. 10 as I said in your, it's soon. 10 things.
So we're not waiting till they get
No.
the lowest of the
Well,
low.
they definitely, you don't have to wait. They're definitely gonna be lower. They're gonna come in at 10:02, 10:03, all the time. Yeah,
I have two questions about the keto.
About what?
Like, okay, so are you allowed to try the mom? But you can rent
No,
the
it's a good
restaurant.
one.
Right.
State license, so I do surgery. I mean, I have.
They're church.
So that's been my stroke plan.
Okay, we're. Where's like, I don't know, expect it. I was thinking if you apply like exactly, yeah, kind of alarm. Like if you're using like the. You can probably hydrocortisone or the candida.
No, you should be able to.
Like a regular.
No, well,
Oh, yeah. I was gonna say, I
No, you were saying that you were waking up at 8 p.m. to get there. I was like, I don't know, I had 8 hours of
Yeah.
sleep. I'm like, wow.
Oh,
Wow.
I have this before, this looks good.
No, not that. No. Yeah. Yeah.
Right away.
okay, folks, let's sit down and get started.
But are we getting enough time to finish all the lectures and go into classes stuff?
We have more than two questions, right?
We only have,
We got clear through the.
and then the stuff. We have 31st and then the second of August.
I don't know, probably not.
If we don't finish that, like,
Well, there could got to be more time, I guess. I'll see. I thought I had, but I'm not sure. Okay, all right. So what's this lesion? Anybody? Patient comes in with lesions like this, what are you gonna do with it?
that scabies.
What?
Scabies
Scabies.
and mineral oil things.
See these lovely linear lines? Okay, this is what scabies looks like. Okay? I thought I'd go into the second week of August.
Our finals start already after, like, 7th is the last week of class.
I have to go over with them because I was supposed to have 13 lectures on you have that 13 lectures. So yeah, okay. So this is what scabies look like. Again, this is really an old picture. Okay, but these papular lesions, they tend to follow the linear lines. Okay, it can be around the rectum. Okay, here it is again. And if you want to know what causes it, this is the nasty thing that causes scabies. Okay, this is caused by a mite. Okay, Sarcoptes scabii. Okay, and basically 1 to 2 millimeter red papules, excoriating, crusting, thread-like burrowing lesions. Okay, not necessarily seen in infants, but they can be there. And the hallmark of these lesions is they itch like crazy. Okay, they really itch. Babies tend to have, if we go back. Okay, in other words, these are the hallmarks here. If you see infants, they tend to have more pustular kinds of lesions in infants. Okay, and the treatment basically is permethrin cream from neck to toes. Leave it on overnight. Now, here's the problem. Once you treat them, you've killed the mite. But the itching is a hypersensitivity reaction, which means it can go on for, okay, long periods of time, even afterwards. Okay, I would use permethrin. I would not use Lindane cream. What's Lindane? Okay, Lindane is basically what's the word? Right out of my, it'll come to me. I'll come to it in a minute. But it's an insecticide. which means it's toxic. So if you're gonna do anything, I'd use permethrin cream. Okay, then we come to the famous thing of head lice, right? Everybody gets nuts about head lice. It's caused by an obligate parasite. It's transmitted by head-to-head contact. Okay, and the nit in the head is the translucent egg, unless you see the louse crawling around the scalp. Okay, and the hallmark of the nit is twofold. One, it's laid close, it's attached to the hair shaft, close to the scalp. If it's 2 inches away from the scalp, this is not a new infection. This is a nit that hasn't been removed from a previous infection because the louse is a blood feeder, and because it's a blood feeder, they lay the eggs close to the scalp. The eggs are attached with crazy glue. They do not come off easily. Okay, and that's where the term nitpicker came from. Okay, the egg is attached, and then you had people who would stand there and pull the nits off one by one because basically that's the only way you get them off. They do not remove easily from the hair shaft. The treatment, you have Nix cream, permethrin shampoo, Lindane and Quell are fine, except you got to know who's using it because, like we said, it's an insecticide and it's only to be used once. But some of these crazy people, okay, wash the scalp with it, kill all the lice, and then when they see the nits that haven't come off, they use it again and they use it again, and then their kids have seizures because of the toxic effect of the insecticide. Um, there is another head shampoo, benzyl alcohol, which is currently used, and there's also now a new treatment out there, heat removal. And when I first heard about it, I figured, oh well, maybe I'd try it in the office. I called to find out, you know, how to get one of these things to use, and apparently it's a branded use. You have to you have to open up a specific clinic to get this type of removal, and it's $250 a head to treat head lice. So again, they wouldn't sell it to me. I tried. Okay, I wasn't going to open up a head louse clinic just to get that. But if you're in communities where they have lots of head lice, that's one of it. The combs that they use, the headlight combs to use out to get the nits off really don't work. You really have to pick them off one at a time, and then you have to wash all the bed linens and clothing in hot water or have them dry clean to get rid of the lice that may be living around there. Okay, get rid of all combs and brushes. And usually, when do we see head lice start? It's in the fall when the kids start going back to school and hanging their clothes up in the same closet with the other kids who may have head lice. And I tell my patients, send your kids to school with black garbage bag, have them throw their coat in it and close it so that if there are any head lice around, it doesn't jump from one kid's jacket to another. Because once the school gets it, okay, then the teachers stand there, okay, with a pencil, Oh, you have a knit, you go home. You have a knit, you go home. And don't get anywhere near that. For the nits are the infectious agent. The infection agent is the head lice. Okay, and the last thing we're going to talk about when it comes to what you call it, dermatology is acne. And we talked about neonatal acne, and we talked about infantile acne. And remember the whole thing. If the message here is if you have increased growth parameters, you want to rule out androgen excess. Okay, and we're talking about axillary or pubic hair, increased growth parameters. These are the kids that get worked up. The treatment that they use on these kids are basically benzoyl peroxide, trimethoprim, or adapalene. Topical antibiotics we don't use. tetracyclines in babies, and oral erythromycin. Okay, mid-childhood acne. These are kids who develop acne somewhere between 1 and 6 years of age. Again, if they're having acne at this age, you must rule out androgen excess. There are certain medications that will increase acne formation in these kids, anticonvulsants, steroids, or INH. But you really want to rule out adrenal or testicular tumors or precocious puberty causing the acne. And the symptomatology, again, is the same as the babies with infantile acne, body odor, axillary hair. Your workup includes testosterone levels, free and total, DHEA sulfate, LH, FSH, prolactin, 17-hydroxy, progesterone, and do a bone age because if they have increased growth parameters, you're going to have increased bone age. Okay, and then we have pre-adolescent acne. This is 7 to 11. This may be the first sign of a kid starting puberty. Okay, when they're developing the secondary sex characteristics. Okay, it's a normal variant. They typically have comedonal acne in the T-zone, and it may predict future severe acne. Again, the treatment is the same as the treatment for adolescent acne, except in this age group, we cannot give tetracyclines. You all know the etiology of acne, hormonal changes, increased sebum productions, formation of a follicular plug, secondary infection by P. acnes, and then inflammatory response. Now, treatment. And, I don't go into long treatment. I'm sure the dermatologist has lectured to you ad nauseum on treatment of acne. There's just a couple of things. Number one, before I treat anybody with acne, you're treating the patient, not the parents. Okay? So you want to know whether the acne is bothering the patient. Okay? What his knowledge of acne is, and I give them a true false test. True or false, acne is related to food. True or false, is acne related to food? It's generally false. Okay? There are some, maybe we'll talk about it, associations, but you don't get acne from chocolate or fries. Okay? True or false, acne is related to dirt. The dirtier your face, the more acne you're going to get. That's false too. And the reason we tell them it's false is those blackheads that you see when they get acne that all the kids are squeezing are not dirt. It's melanin. They're deposited by melanocytes in the hair follicle. Okay. And if they scrub too hard, they're going to worsen their risk of developing acne. So you don't want to make it due to dirt. Okay. Number two, you want to know what they used in the past. You know what proactive is? What's proactive? It's 50 cents worth of benzoyl peroxide with a $100,000 ad campaign. You can get the same thing for a tenth of the price in the pharmacy. All proactive is benzoyl peroxide. Okay, so you want to know what they've been used in the past. Okay, and how fast they're going to get better. Don't come to me 2 weeks before the prom and expect your face to be cleared, because it won't be. Okay, so why do we fail in treatment? Okay, number one, a dominant parent and a reluctant adolescent, you ain't never going to get better. So I always ask is the acne bothering you? If they say no, and I say, do you want treatment for the acne? And they say no, I don't write the prescription. And the reason I don't write the prescription, okay, if the mother spends $50 copay on whatever I write and the kid doesn't use it, you know what's going to go on in the house. More conflict, and they have enough conflict as an adolescent to add something. And that's what I say to them. Tell me when you're ready for the treatment. Tell me when you're fed up with the acne, and we'll take care of it. If the mother drags the kid in and demands treatment, it ain't going to work. Okay, that's number one. Okay? Number two, too many medications. If you give them more than one medication and don't write down the instructions, if you stand there and explain to them how to use the medication you're giving them, their eyes are going to glaze over and they're going to forget everything you've told them. So write down what you're giving them and how to use it. Okay. And if you're giving something too strong, okay, at the beginning, and retinoids are great for acne. There's just one problem with retinoids. What's the side effect of using a retinoid? It dries out your face. That's how it works. So you tell an adolescent, use a pea size, not the whole tube, okay? And they want a quick result, so they more than they should. They smear it all over their face. They go to bed. They wake up in the morning and they tell you they're allergic to the medicine because they woke up with a red hot face. Yeah, well, that's what the retinoid is supposed to do. So if you're going to do it, if I use a pure retinoid, I say to them, pea size, forehead and chin, another pea size, both cheeks. Leave it on for 20 minutes. Wash it off before you go to bed. And do that for 3 or 4 days. If your face doesn't, if you don't wake up with a red face, then leave it off for 40 minutes. If you wake for 3 days. If you wake up in the morning and your face isn't red, then leave it on for an hour, wash it off. And after leaving it on for an hour, and if you're washing it off and your face doesn't turn red, then you can sleep with it all night. It avoids the phone call. It avoids them stop using a medication that you want to use. Okay, so that's the problem with retinoids. And retinoids are not to be used for spot treatment. You don't just dab it on every zit. You put it on your whole face because it's used as a preventative, not as a cure for what you already have. The least irritating one is different, okay? But again, what you write depends upon what the insurance company is going to pay for. Once again, they're telling us how to treat acne. The current consensus for the treatment of acne is starting with a combination of a topical retinoid and antibiotic agent, either a retinoid and benzoyl peroxide, because benzoyl peroxide is an antimicrobial and an anti-inflammatory. Okay, the washes, the kids have body acne, having they use benzoyl peroxide in the shower tends to work. And the use of benzoyl peroxide limits developing a resistance to whatever topical antibiotic that you use. Okay, so again, the combination of what you're going to use is basically what the insurance company is going to pay for. Oral medications in adolescents, you can use minocycline or tetracycline for 3 to 6 months and then taper it. And when do you start tapering the use of oral tetracyclines? The end of April. Why? What happens in May? The sun comes out and they all want to get tan. And if they've been taking oral tetracyclines, you're going to come in with a kid who has, sun exposure and a reaction to the tetracycline. So you never give it to them through the summer, okay? Because they don't listen. Now, there's been some dietary concepts in the management of acne. We'll just go through them briefly. Foods with a high glycemic index, not just French fries, but processed foods or those high in carbohydrates, okay, have an increased risk of worsening acne. The Mediterranean diet or the low glycemic index diet has been demonstrated to improve acne. What about milk? They say milk, can make acne worse, so you should limit milk. These are observational studies. There have never been double-blind studies. It's a weak evidence for milk worsening the acne. Okay, same thing for chocolate. Okay, weak evidence that chocolate makes acne worse. What about whey protein? Okay, whey is in loads of supplements. All these supplements that these kids take and everything else to do bodybuilding and what have you, have whey protein in it. Okay. One whey protein supplement has the equivalent of 6 liters of milk in it. So if you think milk is doing it, then they shouldn't be taking whey protein, even though these are observational studies and have not been demonstrated to make the acne worse. Vitamin D has been shown to decrease acne. So if the kid has acne, you can give them 1,000 milligrams a day of vitamin D, and it may decrease the severity of acne. Vitamin B5, pentothelic acid, randomized controlled studies have shown that it may help with acne, but it has to be high doses. 2.5 grams a day may be effective. Okay? Not anymore, because you go above that, significant side effects may occur. Vitamin A, well, what's Accutane? Accutane is a derivative of vitamin A. So in theory, oral vitamin A have been effective, okay? But again, only in very high doses, and high doses of vitamin A have toxic effects on the brain and skin. So I would not recommend vitamin A as a treatment for acne. And zinc is may be helpful, but only in very high doses, and high doses of zinc have miserable side effects also. So again, dietary concepts, except for vitamin D, are not very helpful in treatment of acne. And if you're out there, I would not recommend you using Accutane. Leave it to the dermatologist, because basically they have to sign a release before the use of Accutane. Every female in childbearing age must go on birth control, because you can't trust them. And if they come pregnant on Accutane, Accutane is teratogenic, so you don't want to use that. Briefly, okay, whoops, what's that? This. What's the diagnosis of this thing? Okay. What's this thing right here? What? This is an accessory nipple. Any lesion that occurs in the nipple line is an accessory nipple. But of course, if it looks like this, any idiot can make the diagnosis. Okay? Because here it looks definitely like this one. Okay? All right. What's this? This is the herald patch of pityriasis rosea. One robin makes the spring, one herald patch makes the pityriasis rosea. They talk to you about pityriasis? Dermatologists show you pictures? Okay? They appear in Christmas tree pattern, right? Okay? And this is basically what they look like. Okay? These oval, scaly lesions. That's what pityriasis looks like. And before I leave, okay, psoriasis. If you want to become an expert in psoriasis, go to Israel, spend 3 days at the Dead Sea, okay? And you'll see more psoriasis than you'll see in your entire medical career, because all of the European countries send their patients to bathe in the Dead Sea for the treatment. So this is psoriasis with these scaling lesions, okay, of an infant. This is psoriasis, again, in the inguinal areas that may look like inflammation. This is psoriasis scales of the scalp. This is guttate. This is plaque psoriasis. This is guttate psoriasis, secondary to infection with groupie strep. And this is psoriasis of the nails. And this is what oral thrush looks like. Okay. And these are Epstein's pearls. Remember I said Epstein pearls, occlusion cyst in the gingiva or midline. That's Epstein pearl. That's the end of dermatology. So in the last hour, we're going to start hematology. And when I talk about hematology, and I know you've all had hematology, right? So I can sit through it, no problem whatsoever, because you'll all be experts in it very quickly. I know that that's not true. Okay? So when we start with hematology, you start with the anemias. And if you're talking about the anemias, okay, you only get anemic for three reasons. Inadequate production of red cells or hemoglobin is one. Okay? Hemolytic anemia due to intrinsic causes. Hemolytic anemia is due to extrinsic causes or blood loss. Those are the only four ways you become anemic. Okay? So you have inadequate red cell or hemoglobin production. Okay? Hemolytic anemia is intrinsically, hemolytic anemia is extrinsically, and blood loss. Okay? Now, we define anemia as the reduction of red cell volume or hemoglobin concentration below the ranges of normal for age, which means you really have to know about ages and hemoglobin levels. Because a hemoglobin of 11 in a kid, this kid is not anemic. Okay? So, and the results you get from your labs are all adult levels. So you should be aware of what's anemia in normal children. Okay? And we defined anemia as a normocytic, megaloblastic, or microcytic. Okay? So, isolated red cell or hemoglobin anemias. Okay? Hypoplastic anemias. Either red cell, the first one is hypoplastic anemias, pure red cell anemias. These are normocytic anemias, and they are extremely rare. Okay, they may be congenital or acquired, and generally they have anemia, reticulocytopenia, low erythroid level precursors in the bone marrow. Okay, so this is diagnosed obviously by bone marrow aspirate. Black fan diamond is the most common. It's a congenital aregenerative anemia. Okay, it presents in infancy. The age of diagnosis is around 3 years of age. It's extremely rare, but 50% of these kids have other problems. They're not just anemic. Okay, they have short stature, craniofacial deformities, defects of the upper extremities. Okay, and the majority are sporadic. Okay, you're not going to see it. Pearson pancreas, Pearson marrow pancreas syndrome is even less common than black fan diamond, and these patients present again in infancy, failure to thrive, pancreatic fibrosis, diabetes, insulin dependent. So these two, you're probably never going to see unless you work for a hematologist. Transient erythroblasticemia of childhood. This is the most common red cell aplasia in childhood. It's more common than the ones we just discussed. It appears somewhere between 6 months and 3 years of age. This is the kid you do a routine blood work on at 2 or 3 years of age, and they got 6 grams of hemoglobin. And they look fine and dandy. They don't look sick at all, okay? And oh my God, what's going on? Does he have leukemia? And you send them off to the hematologist, and they look at the smear and they say, this is transient erythroblasticemia of childhood. If you take a history, these kids generally had some sort of viral infection several weeks prior to the onset of the anemia. It's a temporary failure of erythropoiesis, secondary to transient immunologic suppression. This you may see. It's not very common, but of all of them, this is the one you'll see. And the only other one we include in this category is human parvovirus induced aplastic crisis. Okay, because in typical patients, the human parvovirus has a predilection for pure erythroid cells, so the anemia is more severe. The red cell anemia is more severe than you see in the aplastic anemias, so that's included here. These are not the common ones. Okay, then we have the aplastic anemias, which is a normocytic anemia. It may be congenital, okay? And again, this is not common, it's not congenital, it's not common in children, okay? The normocytic anemias. They not only have an anemia, they have a peripheral pancytopenia. So not only do they have anemia, they have a neutropenia and a thrombocytopenia. Okay, there may be inherited genetic defects or acquired as a result of direct destruction of red cell precursors. The congenital aplastic anemias you ain't never going to see. Okay, Fanconi's anemia has a little bit more than 1,000 known cases, and again, it's congenital, so they have other issues like hyperpigmentation, cafe au lait spots, radial thumb abnormalities, short stature, renal abnormalities. You're not going to see this one. And if they do, they're going to present with other issues. They may have hyperreflexia, microcephaly, or microphthalmia, or ear and hearing deformities. This keratoconus congenital is rarer. There's only 225 known cases. Okay, you're not going to see this one either. It's excellent recessive transmission of Schwachman-Diamond. There's only 200 known cases. You're not going to see these aplastic anemias. What you may see is the acquired aplastic anemias. This is more common in children, and it's a result of destruction of stem cells, either by radiation. Certain drugs could do it. We know, for example, chemotherapy is going to destroy red cell precursors. If you're treating leukemias with chemotherapy, this is what's going to happen. Chronic exposure to benzene can do it as well. Then you have antibiotic exposure. We see it with chloramphenicol. That's why we don't give chloramphenicol to babies, because when we did, it created what was called the gray baby syndrome. What was the gray baby syndrome? We destroyed all their red cells with chloramphenicol, so they turned gray. So we don't give chloramphenicol to babies. Also, anti-epileptics and gold can do it. Certain viruses can destroy erythropoietic stem cells, like cytomegalic EB virus, the hepatitis as well, and then bone marrow replacement by leukemia, myelodysplasia, myelofibrosis, pregnancy, or immune diseases. All these can give you an aplastic anemia acquired. Anemia with normal red cell precursors, we see also the red cell precursors are normal, but these are the anemias of chronic infection, tuberculosis, chronic renal disease, subacute bacterial endocarditis, chronic postoperative effects, inflammatory lesions, juvenile rheumatoid arthritis, collagen vascular disease, sarcoid or inflammatory bowel diseases, and malignancies. Again, the majority of these anemias you're not going to see at all. Then you have the megaloblastic anemias. What did hematology tell you was the most common cause of megaloblastic anemia? Vitamin what?
B12.
Vitamin B12. For me, that is 100% wrong, because children do not get vitamin B12 deficiency. I have never seen vitamin B12 deficiency in children. For my exam, the most common cause of megaloblastic anemia is folic acid deficiency. Okay, that is the most commonest cause of megaloblastic anemias in childhood. The peak incidence of it is 4 to 7 months of age, which is earlier than iron deficiency anemia. And these kids are sick. They fail to thrive. They don't gain weight. They have chronic diarrhea. And because they have chronic diarrhea or malabsorption syndromes, they are either not getting adequate folic acid, which is a little bit unusual since all baby foods are supplemented with folic acid, or they have decreased folate absorption, which is due to malabsorption syndrome, like celiac disease or chronic infective enteritis. Certain drugs as well can give you folic acid deficiency. okay, anticonvulsants, oral contraceptives, and methotrexate. In these young children, the only ones that make are the oral contraceptives. Vitamin B12 deficiency does occur in childhood. It's extremely rare. These kids present with weakness, fatigue, failure to thrive, and irritability. Um, they have pallor because they're anemic. The cardiologists love to test on glossitis with vitamin B12 deficiency. They have multiple other issues, failing to thrive, diarrhea, neurologic symptoms. Okay. And the problem with vitamin B12 deficiency, it can occur in vegetarians. But people who are vegetarians are usually smart enough, if they're vegetarians, to take vitamin B12. So it's unlikely you're going to see it in vegetarians. The rare case of congenital pernicious anemia, okay, this is extremely rare. It's transmitted as an autosomal dominant disorder. Okay, it's the inability to secrete intrinsic factor. Usually, this begins at about a year of age when the B12 stores from the mother that were transmitted transplacentally have been exhausted. But unlike adults, there is no antibody to intrinsic factor. They don't produce. The adolescent form or juvenile pernicious anemia, again, it's rare. It occurs in older children. This is similar to the adult form where they have developed antibodies to intrinsic factor. And these patients have other symptoms, immunologic disorders, cutaneous candidiasis, hypoparathyroidism, and other endocrine abnormalities, and rarely with regional enteritis or babies with necrotizing enterocolitis who had surgery where they removed the ileum. The ileum is where B12 is absorbed, so that these patients may develop vitamin B12 deficiency in childhood. These patients have high MCVs, but patients can also have high MCVs, okay, with no megaloblastic cells. So again, typical megaloblastic anemias, okay, beyond the newborn period, they have an MCV greater than 95. Their reticulocyte count is low, their folate is low, their LDH is increased. That's the typical megaloblastic anemia that you see in childhood, okay? In high MCVs without any of these other problems, patients with liver disease, hypothyroidism, Down syndrome, occasionally aplastic anemias can present with high MCVs without megaloblastic cells. So generally, the message here is megaloblastic anemia is folate deficiency in young children. Okay. Then we have the microcytic anemias. And of the microcytic anemias, the most common of the microcytic anemias is iron deficiency anemia. Okay? This is the most common hematologic disease of infancy and childhood. It results from a lack of sufficient iron for the synthesis of hemoglobin. And to maintain a positive iron balance, you need a 0.8 to 1.5 milligrams per kilo of iron absorbed daily, which means you need 8 to 15 milligrams of iron a day. Nutritional iron deficiency anemia, unlike the megaloblastic anemias, presents somewhere around 9 to 24 months of age. Okay? Why? Because this is when we're weaning the baby from formula or the breast. And the formula has iron in it, but cow's milk does not. Okay? It's rare before 4 to 6 months of age. Now, there's an exception to this numbers rule. If the baby was significantly low birth weight or was a preemie and was in the NICU with the vampires who draw blood on a on a regular basis, who then had to transfuse them, okay, they may develop iron deficiency anemia earlier because of depletion of their iron stores. Then, once you get past the newborn period, adolescents are also susceptible to iron deficiency because they grow rapidly, they require more iron, and because females start with their menses. So basically, in the US, 9% of 1 to 2 year old children are iron deficient, and 3% are anemic, and 9% of adolescent girls are iron deficient, and 2% are anemic. Okay? How do you differentiate between anemia and iron deficiency? What blood test differentiates between what? Not hemoglobin. What? No, not the RBC. Serum ferritin levels. Your serum ferritin levels are a measure of iron stores. So basically, when you start with anemia, your serum ferritin drops first. That's the iron stores. Once you have depletion of serum ferritin, then your serum iron goes down and your iron binding capacity goes up because now you don't have enough iron being provided to for the formation of hemoglobin. Okay, that's once your serum iron drops and your iron binding goes up. That's when the hemoglobin starts to change. That's when the MCH and MCB starts to change. Okay, and then the reticulocyte count may start to rise. Okay, so the most common etiology for the production of iron deficiency anemia in young kids is too much milk and too much carbohydrates, not supplemented with iron. Okay, occasionally there are some children with severe iron deficiency that are iron deficient because they have chronic intestinal blood loss secondary to ingestion of the heat labile protein in cow's milk that's causing microscopic GI bleeding. Older kids with iron deficiency, you have to work ulcers or Meckel's diverticulum. So, what are the clinical manifestations? Well, pallor is the most common sign of iron deficiency. Okay? But you don't want to wait till the kid has 6 grams of hemoglobin and looks pale, okay, to diagnose an iron deficiency. So basically, children should be screened. One of the questions you should ask is, does a kid have pica? Because if you're asking about pica, what do you want to rule out? Lead poisoning. Okay, if a kid has pica, he may have lead poisoning, and we know lead poisoning is a common cause of anemia in children. Do you know what pediophagia is? These are people who eat ice cubes. And if you know anybody that eats ice cubes, screen them for anemia. We're talking about adults. Because pediophagia, people who eat ice cubes regularly basically have pica, okay? And it's secondary to their anemia. Okay, by the time you get down below 5, you may have irritability and anorexia, okay? And then tachycardia, since severe iron deficiency anemia, cardiac debilitation, systolic murmurs, neurologic effects, and effects of intellectual functioning. Okay, I can tell you that making a clinical diagnosis is very difficult because I went to my doctor for my annual and I said to him, "Hey, doc, it's getting harder and harder for me to run around the tennis courts and play tennis for an hour. I play tennis once a week with a pro. Okay, we have a great relationship. She's half my age. She's a sadist. I'm a masochist. I go once a week to be tortured." So I said, "What do you expect? You're 83 years old. You're expected to run around the tennis court slow." And then he did my CBC, and I had 6 grams of hemoglobin. And I knew exactly why I had 6 grams of hemoglobin. He didn't believe me. It was my diet. Okay. but he insisted on an endoscopy and another colonoscopy, which was perfectly normal. Okay, so I started taking iron. My heat well is now 15. Okay, so I had no symptoms other than trouble running around in the tennis court. I wasn't pale, I was lethargic, or any of that. So clinical diagnosis is very difficult to make the diagnosis of anemia. Okay, so you have anemia. Okay, and we said iron deficiency is a microcytic hypochromic anemia. What else causes a microcytic hypochromic anemia? What? The thalassemias. So how can you tell the difference of a patient who's anemic, who shows up with 10 grams of hemoglobin? Do they have thalassemia trait or they are iron deficient? One of the easiest ways to do it is to do it with the red cell distribution width. Did they talk about the RDW? Okay. Well, if you have iron deficiency anemia, basically, and you started off with a red cell this size, and then it got this side, and then it got this side, this size, this side. Okay? Now you have a large distribution between the microcytic hypochromia and normal red cells. You have iron deficiency because you started out with normal cells. If you have thalassemia trait, your red cells were small to begin with. They were basically genetically predetermined. So when you look at the CBC, okay, you're anemic, okay, but your MCV and MCVH are smaller, also are lower than normal. So if you have anemia, low MCH and MCV, but a large red cell distribution with, you have iron deficiency anemia. If you have a normal red cell distribution with, you have thalassemia trait. The only issue here is if your iron deficiency anemia went on long enough, okay, till this continued making them small, then your red cell distribution narrows because you've had the anemia for a significant portion of time. If your CBCs do not give you a red cell distribution width, you can use a Mensa index, which is dividing the number of red cell in millions, okay, by the MCV by the number of red cells in millions. If it's basically over 13, you have iron deficiency. If it's under 13, you have thalassemia trait. Now, microcytic hypochromic anemias, we talked about iron deficiency, the thalassemia traits, either alpha or beta thalassemia trait, chronic blood loss, lead poisoning, okay, or chronic infection can all give you a microcytic hypochromic anemias. Okay, so how do we treat the anemias? Do we send you to the lab for $1 million workup for, serum ferret, iron binding capacity, okay, or do we just put you on iron? We just put you on iron. You put the patient on iron for a month. The hemoglobin should come back to normal within a month. Okay, how much do you put the iron patient on? 4 to 6 milligrams of iron. Okay, 4 to 6 milligrams of elemental iron. Got to be elemental iron. 4 to 6 milligrams of elemental iron a day. Okay, and you can't give it with milk. If you give it with milk, the milk blocks the absorption of iron. So you tell the mother to give them the iron with orange juice. Or citric acid improves the absorption of iron. And the product that I tend to use the best is something called Novaferrum, Novaferrum. And I use the adult preparation. The adult preparation is 125 milligrams of elemental iron per 5 ml. Okay, that's the preparation. So if you have a 10-kilo kid, okay, who's iron deficient, okay, 5 per kilo, he needs 50 milligrams of elemental iron. 1 ml has 25. So if you have a kid who doesn't like to take medicine, you can get 1 ml down into a kid twice a day to improve their iron. It's not hard. Okay, using the other preparations like Ferrensol. Ferrensol smells like rusty pennies. The kid won't take it. Okay, you won't get it near them. On older kids, if they can swallow pills, it's fine. But this one works. It's high concentration of elemental iron in low volumes. It's very easy to give. You put them on it for a month. You bring them back. You do a serum iron, and the hemoglobin's back to normal. Great, you cured their iron deficiency. Did you? No, because you didn't cure their iron stores. And it takes 3 months for the stores to come back to normal. So if you treat a kid and the hemoglobin gets better in a month, you say, okay, we now know it was iron deficiency. Keep an eye on it for another 2 months and you're done. And that's how we treat iron deficiency anemia. Okay, before you do the dollar workup. All right. So basically, those are the inadequate production of red cells or hemoglobin. Okay, um, that's number one. Now we start with the hemolytic anemias. And we have hemolytic anemias due to intrinsic red cell abnormalities or extrinsic functions. And the intrinsic factors that give you increasing hemolytic anemias are number one, defects in the cell wall, defects in the enzymatic composition of the red cell, or defects in hemoglobin synthesis. So the intrinsic factors cause anemia with defects in the cell wall. The number one is hereditary spherocytosis. This is the most common inherited disorder of the red cell membrane. It occurs in about 1 in 5,000 people of Northern European ancestry. 75% are inherited as an autosomal dominant. 25% have no previous family history. So the question is it a new mutation or a new daddy that nobody knows about? Okay. And the abnormality is due to defects in the major component of the red cell cytoskeleton, which means it changes the structure of the red cell. What's the normal structure of a red cell? Biconcave ellipsoid disc. Okay, so it looks like a donut or a bialy. Okay, so you're looking at the red cell. The red cell tends to look like this. So you tend to see central pallor here. I mean, this is what the normal red cell looks like. So when you have a defect in the cytoskeleton, now the red cell, instead of looking like this, becomes round. So when it becomes round, you'll lose the central pallor that you normally see in red cells. Okay? And as these lovely round cells go through the spleen, they are hemolyzed, they rupture. So typically, how does these present? Okay, well, for pediatricians, remember the lecture on neonatology? This is a common cause of hyperbilirubinemia in babies. Okay, baby newborns present with jaundice. They may be anemic. You go back and talk to the mother, and you say to the mother, "Were you ever anemic? Were you anemic during your pregnancy?" "Oh yeah, I was anemic. I took iron and it never got better." Well, she took iron and her anemia never got better. She probably has thalassemia trait, and she gave it to her baby. Okay, older children who get through the newborn period, okay, may be totally asymptomatic. Okay, or once they get, far further along, they may present basically with anemia, pallor, maybe jaundice, maybe fatigue, maybe exercise intolerance. By 2 to 3 years of age, they develop splenomegaly because of the recurrent hemolysis within the spleen. And then by 4 to 5 years of age, they may present with gallstones. Why do they get gallstones? Any breakdown from hemoglobin, regardless of the etiology, can lead to gallstones. So anybody with a chronic hemolytic disease may wind up producing gallstones. And then what happens if they get fifth disease? Okay? they develop an aplastic crisis secondary to their fifth disease. Okay, this is the most serious that we see. This is the most serious complication. Okay, now generally these kids run hemoglobin somewhere between 6 and 10 grams per deciliter. If they're asymptomatic, we basically do nothing. Okay, if they become symptomatic or the hemoglobin get too low, we can't change the cytoskeleton of the red cells, so we take out the spleen. If we take out the spleen, we're getting rid of the main organ that results in hemolysis in these kids. Okay, and basically this will produce a clinical response in their hemolytic disease, and their hemoglobins will improve. If you're going to do it, you do it at after the age of 5 to 6, and then you have to do everything to avoid sepsis in a patient whose spleen is removed. Hereditary erythrocytosis is an uncommon disorder, and unless you're treating people who come from West Africa, you're probably not going to see it. It's rare in Western populations, and again, it's inherited as an autosomal dominant trait. But besides hereditary erythrocytosis, there are other things that can give you the picture of erythrocytosis. Iron deficiency, B12, and folic acid can also present with erythrocytosis. And the rarest form is hereditary stomatocytosis. This is extremely rare. Okay. It may be inherited or acquired. It's seen in liver disease. And when you look at the red cells, they smile back at you because there's a horizontal slit in the red cell. This is not very common. Then you have the enzymatic defects. Pyruvate kinase defect. Well, the enzymatic defects, there are two enzymes in the red cell, the glycolytic pathway and the G6PD pathway, the hexomonophosphate pathway. Those are the two enzymatic pathways within the red cell. The glycolytic pathway, these kids are all very sick. Okay, this isn't a benign where you're going to see them. Pyruvate kinase is the most common. Okay, it's seen in Ashkenazi Jews. No, excuse me. It's seen in the Amish of the Midwest, and there are only 300 to 400 reported cases. It's transmitted as an autosomal dominant, and you're not going to see this unless you're practicing in the Midwest in the Amish community. Okay, and these kids have severe jaundice in the newborn period. They develop kernicterus, older children, pallid jaundice, and splenomegaly. So this one you're not going to see. The phosphorythroid kinase deficiency is seen in the Ashkenazi Jew, okay, and it's also associated with a glycogen storage disease. Once again, these kids are significantly ill. It's not a benign disease. And then triphosphate and phosphoglycerate kinase, again, are not very common. So the glycolytic pathway defects are zebras. You're not going to see them. And you know what I mean by zebras, right? Everybody know what I mean by zebras in medicine? Okay. The hexomonophosphate pathway, this is the glucose 6-phosphate dehydrogenase. What's the purpose of G6PD in the red cell anyway? Why do we have it in the red cell to begin with? Okay? It protects the red cell from basically deoxygenation. Okay? And there are two forms of G6PD deficiency, the acute and the chronic. And I'm not going, my notes give you nauseating detail. There's two breakdowns of C6PD deficiency, A and B. I don't care. Okay. And basically, okay, they're usually triggered by drugs. All right. What did they teach you is the most common trigger for G6PD episodes? Probably, right? They only kind of find it, okay? You know what's a more common trigger for G6B deficiency or G6B episodes? What? No. It's something you give to newborns. Vitamin K can trigger G6B deficiency. Okay, that is one of the most common precipitators of G6B deficiency. Yes, the sulfonamides can do. And who eats fava beans here? That's what I thought. Okay, fava beans cause it. Everybody in this classroom eats fava. All right. That's why I bring it up. They always teach fava bean. I don't know anybody who eats fava bean. Okay, so it ain't fava bean. Sulfonamides can do it, absolutely. Antimalarials can do it as well as aspirin, phenacetin. Okay, these are the ones that can trigger G6B deficiency. Okay, and again, the trigger of the hemolysis depends on the agent administered, okay, and how severe the hemolysis is. So you should be aware that that's why now, at least in the state of New York, every newborn's being screened for G6B deficiency. So you know that if a baby certainly develops jaundice, because G6PD is given, vitamin K is given in the delivery room, and it depends how long the kid stays in the hospital, how long it will take for the jaundice to appear in this baby, because they're throwing mothers out at 24 hours of age. So you start hemolysis, and at hour 1, okay, and they go home at 24 hours. They may show up at the pediatrician's office in 24 hours or 48 hours, and they may be jaundiced, and it could have been due to G6B deficiency. So now we know all babies are screened before they leave the hospital for G6B deficiency. Okay, so we have structural defects. Then we have deficits in hemoglobin synthesis. Okay, and the first one on the list is sickle cell anemia, as my patients used to call it. Okay, I have sickle cell anemia. So that again, we know where the genetic defect for sickle cell is. It's on chromosomes 11 or 16. Okay, there are 700 different variants for sickle cell disease. The majority are extremely rare. And sickle cell disease is a chronic hemolytic disease, okay, with superimposed episodes. In the United States, it occurs in 1 in 625 African American births, which means there are 70,000 Americans that carry sickle cell disease, and worldwide 3.5 million people have sickle cell disease. And how did sickle cell disease originate anyway? Why did we get what? It's resistant to malaria. So it only occurred in countries that had malaria. So basically, there were no sickle cell anemia in Caribbean blacks. Caribbean blacks had never had any sickle cell anemia, okay, because there was no malaria in the Caribbean. Okay, then when the slave trade started and there was intermarriage, that's when people from the Caribbean eventually developed sickle cell anemia as well. It can also be seen in Hispanics, people from Arabia, or it can occur in American whites, Caucasians, or Indians, but extremely rare. Okay, newborns don't show symptoms of sickle cell anemia. Why? They have fetal hemoglobin. Okay, so they don't. So the symptoms, the hemolysis doesn't begin until they're somewhere between 2 and 4 months of age. Okay, as fetal hemoglobin decreases. They usually don't become symptomatic for 5 or 6 months of age. Okay, and by 5, 95% of children with sickle cell disease will have functional asthenia. Why? Why don't they have a spleen by the time they're 5? Because they're infarcting their livers on a regular basis by the sickle cells sludging within the spleen. So they have a functional asplenia by the time they're 5 or 6 years old. That's why they're at greater risk for gram-negative sepsis. almost 300 times higher in sickle cell patients. Okay. Now, the presentation or the crises have various forms, and the earliest crisis is hand-foot syndrome. Hand-foot syndrome is an acute dactylitis. Frequently, it's the first sign of sickle cell. It presents as symmetrical, painful swelling of the hands and feet due to ischemic necrosis of the small bones. It usually occurs before the age of 2, and if it does, it indicates that you have severe sickle cell anemia. Okay, the most common presentation of sickle cell anemia is painful or vaso-occlusive crisis. This is the most frequent and prominent manifestation of sickle cell disease. In younger children, it involves the extremities. As they get older, pain involves the head, chest, and abdomen. The sickling is triggered by fever, hypoxia, acidosis can trigger the crisis. And the crisis may present with abdominal pain that may mimic an acute abdomen. It may present with bone pain. And if you take an x-ray, it looks like an osteomyelitis. When it isn't an osteomyelitis, the changes are secondary to the lytic changes of sickle cell disease. And if you do a CBC on these patients, it's normal. There is no changes in the hematologic picture, even if they have an acute crisis. The two other forms, sequestration crisis, okay, this occurs in children between 6 months and 3 years of age. Okay, you have huge amounts of blood being pulled in the spleen for some unknown reason, and the spleen enlarges so that, the head of the spleen is down into the pelvis. Okay, that's how large it gets. Okay, and these patients present with massive circulatory collapse because all their blood is being pulled into the spleen. Okay, and this is an important cause of death in infants with sickle cell disease. It doesn't occur after the age of 5. Why not? I just told you the spleen is fibrotic. If the spleen is fibrotic, it can enlarge and have this massive sequestration. And then an aplastic crisis with our friend human parvovirus 19. Okay, and these patients will present with an aplastic crisis with a significant change in their hematologic picture. Okay, now the issue with sickle cell disease, okay, is patients are living longer with new treatments and new management. They're living longer, and because they're living longer, they have new problems. Number one, we're able to diagnose sickle cell disease in infancy, so we can start treatment and look for it early on. So we know they're prone to infections, particularly with pneumococcus and gram-negative organisms. So you want to immunize them early. You want to prevent infections. They go on prophylactic penicillin beginning at 2 months of age to prevent any infection that may come down. Okay, any febrile illness has to be promptly treated. Okay, because they have thrombotic episodes. Okay, 20 to 30% of children may have occult strokes that you don't even know about. Okay, the stroke risk is 15% per year of age in 6 to 9 year olds. So they may present with intellectual impairment early on, which can only be diagnosed by neurocognitive testing and MRIs before MRIs if indicated. If they need transfusions, anytime you transfuse a patient, they're at risk for sensitization, not just with major blood groups, but the minor KEL groups as well. So if you're going to transfuse patients with sickle cell disease, basically they should go more extensive blood typing before you transfuse them. And with recurrent transfusions, you run the risk of overload and hemosiderosis, meaning they may need chelation therapy. Lung injuries are common as they get older. So they have these patients you want to treat with incentive spirometry, measure their abilities early on. They get treated with macrolides, okay, and asthma treatments to prevent issues with chronic lung disease, okay. One of the treatments out there for sickle cells is giving patients hydroxyurea. Why do we give patients with sickle cell anemia hydroxyurea? Because it increases fetal hemoglobin. And if you increase the production of fetal hemoglobin, you reduce the risk of sickling in these patients. 50 to 60% of patients who live long enough can develop pulmonary hypertension. So you want to do everything to reduce the risk in that. If they get to the age of 35, they're at risk of avascular necrosis of the femoral head. Most of them died before 35. Now they're living longer, so they wind up needing treatment for their avascular necrosis of the femoral head with decompressive coring of the hip or hip replacement. They all develop gallstones. Why? I just told you. Any patient with chronic hemolysis may develop gallstones, okay, and may need a laparoscopic cholecystectomy. Okay. Now, there are treatments out there now for sickle cell disease. Okay. Can we cure sickle cell disease? What?
There's only genetic stuff that they're.
Sure we can. Bone marrow transplantation will cure sickle cell disease if you can find basically an appropriate donor. Okay, bone marrow transplantation will cure them, but bone marrow transplantation is a little difficult to do. Okay, so now there's CRISPR manipulation of these patients, not just the sickle cell, but for beta thalassemia as well. Okay, they take a bone marrow. They basically alter the red cells of the patient. Okay, they alter the hemopoietic bone cells. Okay, and then you give them an infusion of this CRISPR alternating red cells. Okay, and it gets into the bone marrow, and basically you get a response. Okay, it's remarkable that they're doing this stuff. Okay, that they're able to do this, and basically by doing it, okay, it prevents the red cells from hemolyzing. There's a drug out there that can prevent the deoxygenation of the sickle cell. If it prevents the deoxygenation, you prevent the cells from sickling. So the CRISPR was originally approved for 5 to 11 years old. This month, it's just been approved for 2-year-olds. So you're going to see more and more of sicklers being treated, and maybe the burden of sickle cell on these patients is going to be improved. There's other sickle cell syndromes, beta thalassemia and sickle cell. You get one trait of each. Okay. Sickle beta thalassemia is a severe sickle cell anemia as well. But what about sickle cell trait? Sickle cell trait is hematologically silent. You can't blame any anemia or anything on a patient having sickle cell trait. Okay, it's pervasive throughout the world. 7 to 10% of African Americans have the trait. Okay, um, the incidence is higher on hemoglobin electrophoresis because alpha thalassemias, patients who have alpha thalassemia, up to a third of them can also have hemoglobin S as well. The lifespan of sickle cell trait is extremely normal. Complications are very rare, except, okay, sudden death can occur in sicklers who have heavy exercise. And I don't understand this, but colleges want sickle cell tests on all of their athletes, particularly their football players, regardless of their race. So we're doing sickle cell preps on Caucasians. Okay? And I know that positive on any of the Caucasians. I know, but I mean, if they're not from a mixed race family, okay, they're not carrying it. But the lawyers say everybody needs a test for sickle cell trait so we know if they're playing football. Okay. You can get splenic ruptures at high altitudes. So basically, I wouldn't have them climbing Mount Everest or doing deep sea diving. Okay. But again, none of these have been well studied. But we know hypoxia can induce sickling. So why would you climb Mount Everest if you have sickle cell trait? Because we know that in the renal medulla, which is relatively hypoxic and acidic, it can cause sickle cell trait can cause hematuria because they're having microthrombi within the kidney because of its condition. Why subject yourself to that? And then there are other hemoglobinopathies, which are very rare. Hemoglobin C, okay, is a hemolytic anemia, and any hemolytic anemia can result in splenomegaly, anemia, and gallstones. Okay, so hemoglobin C, E, and D are also out there that can give you the incidence of similar to sickle cell disease, meaning you can have sickling or hemolysis with gallstones and anemia. And I'll stop here, and when I come back next week, we'll finish up on hematology. And when I'm done with hematology, I'll start GR.
Child gets like.
What?
So no,
Thank you.
I have.
Actually,
yeah, the Christmas,
I'm gonna add that.
Yeah.
Very cool now. Yeah.
Yeah.
no,
Thanks very much.
yeah.
Good to know. Like.
I think initial activity.